This is the Psychcast by MD Edge. I'm the voice of MD Edge Podcasts, Nick Andrews. And welcome to episode 141 of the Psychcast. I'm Nick Andrews. In this edition, we've got a Masterclass lecture for you. Dr. Sanjay Gupta is here to discuss the behavioral symptoms of dementia and the psychological symptoms of dementia and what you could do to manage them. You can find all the relevant information in the show notes. Remember, you can email the Psychcast at podcast@mdedge.com, and you can follow us on Twitter at mdedgepsych. And without any further ado, let's just get right into what you're here for. Masterclass lecture. Please welcome Dr. Sanjay Gupta.
My name is Dr. Sanjay Gupta. I practice in Buffalo, and my practice involves being the chief medical officer at Bryland Hospital, which is a private hospital in Buffalo. It also involves being on the faculty at two medical schools, the State University of New York at Syracuse, as well as the Jacobs School of Medicine in Buffalo, where at both places I'm a clinical professor in the departments of psychiatry. In addition, I practice at, let's start again, didn't come well, okay? So, my name is Dr. Sanjay Gupta. I practice in Buffalo, New York. My practice involves being the chief medical officer at Bryland Hospital in Buffalo, New York. And also, I'm the faculty at two medical schools, the State University of New York in Syracuse and the Jacobs School of Medicine in Buffalo. I am on the faculty of both medical schools as a clinical professor. As part of my clinical duties, I attend at 8 to 10 nursing homes at any time. So seeing patients with behavioral and psychological symptoms of dementia is a good part of my practice. So today's talk is going to be based on dealing with these patients, in other words, assessing them, treating them, talking to families. As you all know, the baby boomers are aging. And my friend, Dr. Tumpy, says there are three kinds of tsunamis coming. One, the baby boomers aging, as I just said. Two, older adults with substance use disorder. And three, older adults with serious and persistent mental illness. So these are the three tsunamis we're going to face in the long-term care setting, or if you're seeing older adults in your practice in any shape or form. Now, there are a lot of meta-analyses have been conducted with the use of psychotropic medications for older adults with behavioral and psychological symptoms of dementia. So most of the meta-analyses are with antipsychotics, followed by a few with antidepressants and a couple with mood stabilizers. Now let's first define the neuropsychiatric symptoms as they occur in patients with dementia. There's agitation, which can occur in 80%, aggression, delusions, insomnia, anxiety, and depression. About 1/3 of community-dwelling elders, those who live in the community, may have these neuropsychiatric symptoms, and 60 to 80% of the skilled nursing facility population may have these symptoms. And these symptoms do fluctuate over time. So when we look at assessing these symptoms, the most important thing is to get a detailed history. When you and I go into a clinical facility, or when you and I talk to an older adult in our practice, they reveal very little. And hence, it's very important to get collateral information from either the spouse, the relative, or staff members in the facility. If they are in a nursing facility, the staff members provide excellent collateral information. But we need to train the staff members to the kind of information they need Otherwise, we get non-specific information like confused, which doesn't really go anywhere. But we need to know the person has disorganized thought, they are hallucinating, they are seeing spiders, those kinds of things. It's important for the staff member to give us the right information. Often in our office practice, when we see these patients, we may need to meet with the spouse separately, as in front of the index patient, the spouse may not feel comfortable talking about the paranoid ideation or the aggressive behavior that their husband or wife or their significant other does at night. So I think a private meeting is always helpful in these cases. And that calls for a thorough assessment. Collateral information from additional sources is very important. Now, the most common medicines that are used to treat these symptoms when they're diagnosed are the antipsychotic drugs. Now, remember, all these treatments are considered off-label based on the FDA's approach. So antipsychotic drugs overall have modest efficacy data. So the selection of the patient has to be accurate. So based on my review, Risperidone has the most studies in this area, followed by olanzapine and aripiprazole. Quetiapine has limited data. Now, when we use antipsychotic drugs, there are a couple of things that we really need to worry about. One is the cardiovascular adverse events, which are thought to be higher with risperidone. And also there is the boxed warning from the FDA with regard to the antipsychotic drugs of increased mortality. It's 1.6 to 1.7 times placebo based on the placebo-controlled trials. I think this data came out in somewhere around 2005. Now, antipsychotic drugs work well when there's aggression or paranoia, delusions of persecution. People may be imagining that the staff are stealing their money, staff are stealing their toothbrush, things like that. That's when they work well. They just don't work very well when somebody says non-specifically they're agitated. A person may be agitated because they may be in pain. They may be agitated because they may have a full bladder. They could be agitated due to sensory deprivation. And in the current pandemic, we have seen a lot of this, that the elders have been deprived of their loved ones meeting them. That has resulted in not only depression, it has also resulted in agitation. And I think that sensory stimulation is so important. I just was having a meeting with a lady, it was a telephone meeting, and her mother was in one nursing home where she was not getting enough activities. And the mother was depressed, expressing suicidal thoughts. We did not use antidepressants, we just placed her on a watch. She was transferred to another nursing home within the same group where there's a lot of sensory stimulation. And the lady, the older adult, is a changed person. And I thought, now, I didn't think that I needed to prescribe any antidepressant medicines to her. And so the environment, the stimulation is so important, which in this time of the pandemic is really been a tough time with the outbreak of COVID and restrictions of loved ones being able to go into the nursing home. So we have to consider the importance of the side effects of antipsychotics being greater in the older adults. They're more sensitive. So extrapyramidal symptoms, sedation, gait problems, falls, all these are real things that can happen. You know, fall and fracture hip goes really in the negative direction. Also, the long-term side effect of tardive dyskinesia can occur with as little as 1 month's exposure to an antipsychotic drug. Now, assuming that we have detected agitation, aggression, paranoia, psychosis, we have assessed the patient adequately, and we have documented that non-pharmacological interventions have failed, and we are planning to use an antipsychotic medication, I think it's very important to first talk to the healthcare proxy because you don't have consent otherwise. So we need to get informed consent from the healthcare proxy. When I talk to the healthcare proxy, which is usually the son or the daughter, about 70% of the time it is the daughter, I usually have a conversation about the symptoms, the treatment, lack of treatment, and if there are any other treatments. And I always emphasize the fact that this is a non-FDA approved treatment. And they need to understand what non-FDA means. And also, in the same breath, I also tell them about side effects like stroke and sudden death. And then I come around and saying that, look, there are other medicines we take which have side effects, but we nevertheless take them. And often the son or daughter or the healthcare proxy may not understand why you're switching from an antidepressant to an antipsychotic, because commonly antidepressants get prescribed for agitation. And I might have to explain to them in very layman terms that would you give an anti-diabetic drug to treat high blood pressure? And that's why we're using the antipsychotic to treat the aggression, the agitation, or the psychosis versus an antidepressant which is not working. And also the most data, even though modest, favors the antipsychotic. So I most commonly use the atypical antipsychotic. The Risperidone is the most common one. Why? Because it's most studied and we have a leg to stand on. Why? Because there are many studies for it. A starting dose is very low, like 1/4 milligram twice a day, 0.25 twice a day. The maximum dose is 2 milligrams in a total of 24 hours. Maybe less if not well tolerated. Same thing with olanzapine, starting dose 2.5, maximum dose is 10 based on tolerability. Aripiprazole, starting dose 1 milligram, and maybe maximum dose is about 5 milligrams or less. Now, this is also something that I discuss with the healthcare proxy, and I might give them an estimate of what the dose would be in an adult person versus their mother or father. So it is easier for them to understand the difference in dosing in older adults. And I also tell them, look, just because we started this doesn't mean we can't stop it. I tell them you have the final say, and you could call anytime and tell the staff that we need to stop this medicine. So I think having a telephonic discussion is really helpful in getting this informed consent process going, which I think is very important. Now, most of the studies, as I said, have been done with antipsychotics. There are some studies with SSRIs. People have tried fluoxetine, sertraline. They've also tried citalopram. They have mild effects in most cases, not very extensive. Valproic acid or divalproix has also been tried, but overall, there are no clinical benefits, but there are side effects. In some cases, melatonin may help, mostly helps improve sleep. But there was one study where it seemed to help with behavioral symptoms. Trazodone was an older generic drug which was used in the past before the atypical antipsychotics began to be used, and it was known to help with sleep and some non-specific aggression and agitation. The anti-dementia drugs like donazepam and memantine help in the early stages. In the later stages, less likely to. Now, the dextromethorphan and quinidine combination, which comes under the trade name of New Dexta, has also been shown to help. But again, that's an off-label use. This drug has been on label for pseudobulbar affect. There are other studies which are suggestive of use of medical cannabis and brexpiprazole is being tried. So a lot of things, but I think one is best starting with medicines that are most tried with the most trials and then go down the line. There's also a segment of data on trial of analgesics for behavioral and psychological symptoms of dementia. And the studies were done in the older adults, like 80, 85 plus. They were 8-week trials, and they used the drug acetaminophen. Oral morphine was tried, buprenorphine was tried, pregabalin. So these are, if you go to the American Geriatrics Society, AGS, they have protocols for doing these. I don't think we can go into each one in detail for the purposes of this talk, but I'm just giving you a broad outline. Now let me share with you some clinical tips. When I examine a patient, I get information through the patient interview, through the chart. Also, I get information from the staff and the family member, and I get a sense of, do we have a depressive theme? Do we have a psychotic theme? Do we have a highly sexual theme? Okay. If we have a depressive theme, I might most likely try an antidepressant. And I most commonly may use sertraline, citalopram, or mirtazapine. These are helpful. And they each have their advantages and disadvantages. If I have a general idea of a psychotic theme, and that would be this paranoia, delusional thinking, hallucinations, I might use risperidone first, okay? Now, if I have somebody who's highly sexualized, in that case, I might try divalproex. The trouble with divalproex is it takes a lot to titrate. You have to do blood levels. And by the time the nursing staff calls you, they've already tried a lot and they need that person in control yesterday. So I might, in that case, then end up using an antipsychotic like risperidone and get things under the control and then get a transition to divalproex or leave them on risperidone, okay? So I think in the first few 1 or 2 weeks of using this medicine, I might also give a order for 0.5 milligram of lorazepam for sudden agitation, because I think that there will be some breakthrough episodes. Until things are well controlled, we need to do this. Once we've got the patient settled, my visits are a lot less. Initially, I'll see them, depending on the status, maybe in a week or 2 weeks, and then it goes to a month. And the people who are very stable, I see them every 3 months. I think you have to just look at this situation like your own outpatient clinical practice, even though it's in a skilled nursing facility, assisted living, or in the office. We look at it the very same way, in my opinion. Now, I think the important other aspect is there's this whole thing called gradual dose reduction. We need to do that too, to see if they can be on the minimal possible doses of the antipsychotic medication. And that's important. So if I decide that this patient would best benefit from being on risperidone, then I might stop all the other medicines. And then ultimately what ends up happening is they might get taken off 2-3 drugs and just be on one. And that's also a good way to talk to the family. Look, they're on 4 psychotropic medicines. We're going to use one. We're going to be down 2 or 3, which everybody appreciates. So I always encourage the family to have a meeting in a treatment team and see what medicines are essential for their loved ones and what are not. Now, so having said all this, in times of the pandemic, it has been a different challenge. I have not been going into the nursing facilities, and I'm using, because of HIPAA being suspended or actually, being loosened up, I'm doing FaceTime. We do a doximity, whatever works, and that seems to work pretty well. Actually, I still get a very good feel for the patient, and you just need to see them more often if you need to. And usually the nurses all have a cell phone, or they have iPads at the facilities, which are able to do Apple FaceTime or doximity, and these seem to work very well. I think in nursing facilities, it's hard to do Zoom because you have to schedule things, and the patient may be in their own room, and if it's easier for them to just carry the iPad into the patient's room and you can see everything, including the nurse can move the iPad around so you can see their legs, you can see their hands to see if they have a tremor, You can also see their mouth to see if they have tongue movements due to tardive dyskinesia. So I think overall, I would say one needs to see how much disruption is caused by these behavioral and psychological symptoms and go from there. Most importantly, also, I should mention, we should also make sure that they're medically okay. So I order some labs like electrolytes, urine culture, because often if they have an infection brewing going, there may be elevated WBC, urine culture may be positive for infections, and they have a behavioral change. We want to, of course, exclude that before we give them psychotropic medicine. So I will stop here.
And that's it for episode 141 of the Psychcast. I am Nick Andrews. The Psychcast is produced by MD Edge editors Gina Henderson and Jeff Bauer. I am the audio engineer and audio editor for this show, Nick Andrews. All MD Edge podcasts are produced by MD Edge executive editor Kathy Skarbeck and the senior vice president for editorial at Medscape, Dr. Ivan Aransky. The editor-in-chief of MD Edge Psychiatry is Dr. Lorenzo Norris, and the show notes are authored by Dr. Jacqueline Posada. You're listening to the Psychcast by MD Edge.